Hello and welcome to the Columbia Department of Psychiatry Grand Rounds. My name is Jean Marie Alves Bradford, and I am the director of the Department of Psychiatry's Office of Equity, Diversity, and Inclusion. Our office is coordinating a series of Grand Round talks on addressing structural racism, and today is our first presentation. Next week, our Grand Rounds will be on culturally centering medications for opioid use disorder, community engaged implementation research with tribal partners by Dr. Amy Campbell, Associate Professor of Clinical Psychiatric Social Work here at Columbia. Today, I am very delighted to welcome Drs. Ruth Shim and Sarah Vinson here for this first session in our office's Addressing Structural Racism series. Their presentation today is entitled Social Injustice and Mental Health, and it is my pleasure to tell you more about them. Dr. Ruth Shim is a Luce and Grace Kim professor, Luke and Grace Kim professor in cultural psychiatry and professor of clinical psychiatry in the Department of Psychiatry and Behavioral Sciences at the University of California, Davis. She also serves as the Associate Dean of Diverse and Inclusive Education at Davis School of Medicine. And Dr. Shim received a MPH in Health Policy from Rollins School of Public Health at Emory University and an MD from Emory as well. She is a member of the Board of Trustees at the Robert Wood Johnson Foundation and the American Association for Community Psychiatry. She serves on the Research and Evaluation Committee of the California Mental Health Services Oversight and Accountability Commission, and she serves on editorial boards of JAMA Psychiatry, Psychiatric Services, Community Mental Health Journal, and the American Psychiatric Publishing, and is a co-editor of the books The Social Determinants of Mental Health and the recently published Social Injustice and Mental Health, which we'll hear more about today. She is a former fellow of the Executive Leadership in Academic Medicine, the ELAM program, and an at-large member of the National Academies of Science, Engineering, and Medicine Forum on Mental Health and Substance Use Disorders. Dr. Shim's research focuses on mental health disparities and inequities, and she provides clinical psychiatric care in the UC Davis Early Diagnosis and Preventative Treatment Clinic. Dr. Sarah Vinson is a triple board certified physician who specializes in adult, child, adolescent, and forensic psychiatry. Along with Dr. Shim, she is the co-editor of the text Social Injustice and Mental Health. In addition to providing clinical care to a culturally and socioeconomically diverse clientele, she is the founder of Loyo Forensics, a multidisciplinary, culturally and structurally informed forensic mental health consultation company. Dr. Vinson graduated summa cum laude from Florida A&M University. After graduating from medical school at the University of Florida with research honors and as an inductee in the Chapman Humanism Honor Society, she completed her general psychiatric training at Cambridge Health Alliance, Harvard Medical School. While there, she also received specialized training in trauma through the Victims of Violence program. She then returned to the South to complete fellowships in both child and adolescent and forensic psychiatry at Emory School of Medicine. Dr. Vinson is Associate Clinical Professor of Psychiatry and Pediatrics at Morehouse School of Medicine, where she was the lead architect and is the program director for the Child Psychiatry Fellowship, and which is the first and only at an HBCU medical school. She is also adjunct faculty at Emory School of Medicine, and she has been elected and or appointed to national and statewide office by her professional peers. She serves on the boards of the American Association of Community Psychiatry and of the Brazelton Center for Mental Health Law. She is also one of 2 national psychiatric advisors for the Judges Psychiatry Leadership Initiative, a collaboration between the Council of State Governments and the American Psychiatric Association that designs and delivers trainings for judges regarding mental health and criminal justice. Additionally, at the invitation of the Conference of Chief Justices and Conference of the State Court Administrators, she serves on the National Judicial Task Force to examine state courts' response to mental health. Dr. Shim and Dr. Vincent, I'm very excited to welcome you here. I see Dr. Lieberman is here. Would you like to say additional words?
Nope, you said it all.
Okay, thank you. Dr. Shim and Dr. Vincent, please take it away.
So thank you so much, Dr. Alves Bradford. Dr. Vinson and I are so pleased to be joining you all remotely me from California and Dr. Vinson from Atlanta, and we're just happy to be here today. We have a lot to cover in a little bit of time, and we really want to make sure that we have enough time to have a really rich discussion. So I'm going to launch right in. So today we're going to spend a little bit of time defining some key concepts associated with social justice and mental health. We're going to take a little bit of time to evaluate the evidence that's available on social injustice and behavioral health outcomes. And then we're going to take some time to identify some solutions to dismantle social injustice in psychiatry. I have no major disclosures to make, but I always have to make a disclaimer before we start on these types of topics. And the reason is because these concepts are a little bit difficult, they're a little bit uncomfortable. And as a result, some complex feelings are most likely going to emerge as we move through this content. And some of those feelings include things like guilt or anger or resentment or defensiveness. You may perceive me or Dr. Vinson of perhaps accusing you of being racist or sexist or any number of other things. You may feel that both of us have some sort of political agenda. Perhaps we lack some sort of objectivity. All of these emotions may come to the surface. I bring up that you may feel these things because these are all feedback that we have received when we talk about these topics. So as psychiatrists and mental health professionals, if we cannot explore difficult topics and do that exploration without being able to look at ourselves, then we're not going to make the progress that we need to make in this space. So if you start to notice those emotions, it's fine. It's a good time to look within, question where those emotions are coming from, and also to remember the words of James Baldwin, who said that I'm not interested in anybody's guilt. Guilt is a luxury that we can no longer afford. I know you didn't do it and I didn't do it either, but I am responsible for it because I am a man and a citizen of this country, and you are responsible for it for the very same reason. So with that, I think we can launch into our discussion today. And so the title of this talk is Social Injustice and Mental Health. And so in order for us to talk about social injustice, we need to consider the concept of social justice. And social justice is actually a pretty controversial and political topic. And so this article in the Wall Street Journal was published by Dr. Stanley Goldfarb, who at the time was Associate Dean of Curriculum at the University of Pennsylvania. The title of this op-ed was Take 2 Aspirin and Call Me by My Pronouns. And Dr. Goldfarb lamented the idea that social justice curricula were moving into medical schools at what he described as woke medical schools, and said that it was getting in the way of the core purpose of what it meant to be a doctor. One of the things he said in that op-ed is, why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients? And so that is a perspective that a lot of people have, this idea that maybe there is too much focus on social justice, especially when we think about it as it relates to medicine. Several of his colleagues at the University of Pennsylvania published a response to this op-ed in the Philadelphia Inquirer. They mentioned that social and health policies have always determined who gets sick and who gets care and where and how. Understanding the social drivers of health and illness is not peripheral or tangential to health. It is the key to diagnosing and meeting a patient's fundamental needs. So again, it's controversial. There's debate about it. And I think that when we think about things that are controversial, it's important that we have good working definitions. And so social justice is in fact a philosophical concept. And David Miller defined social justice as the distribution of good or advantages and bad or disadvantages in society, and specifically how these things should be distributed in society. It's concerned with the ways that resources are allocated to people by social institutions. And I would also add to that another philosopher's addition to the definition of social justice, which John Rawls said was assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. I think that's a really critical piece to think about when we talk about this concept, particularly because we know that people with serious mental illness are often the least advantaged members of our society. And when you add that to a number of intersecting levels of oppression, whenever we are talking about people with serious mental illness and people who are oppressed and marginalized with serious mental illness and substance use disorders, we're really almost always talking about these concepts. So it is important that we make a very clear distinction as we move through this topic today. And that is the distinction between health disparities and health inequities. And we often in the United States spend a lot of time talking about this concept of health disparities. So I want to define it as defined by the World Health Organization. They said that health disparities are differences in health status among distinct segments of the population, including differences that occur by gender, race or ethnicity, education or income, disability, or where you live. Now, it's really important for us to contrast that with the idea of health inequities. So that is defined as disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. The reason it's so important to contrast these two concepts is we often spend a lot of time talking about this idea of health disparities. We talk about differences in health. But if you're not talking about what the cause of those differences are among populations, you have the tendency to default to seeding the cause or saying that the pathology or the cause of the difference lies within either the individual or within that particular population that you're talking about. And so if we say that there are differences in rates of schizophrenia with certain populations, if we do not describe the systemic, avoidable, and unjust social and economic policies and practices that lead to those differences, if we just say that they're differences and don't say why, people tend to default to thinking that there's some type of biological or perhaps cultural or some sort of individual difference within that population that's driving the difference. And I would say actually probably 95 to 99% of the time, the differences that we see in mental health outcomes and substance use outcomes in this country has to do with systemic, avoidable, and unjust social and economic policies and practices, and not because of some sort of biological difference or because of some sort of cultural difference in the ways that people think about illness or think about that concept. I want us to remember that because we're gonna give examples of that throughout this talk. So it's really important then when we talk about this that we also reference the social determinants of mental health. And just to remind everybody, I think we're all familiar with this concept, but I will make sure that we define it as the societal, environmental, and economic conditions that impact and affect mental health outcomes across various populations. These conditions are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. And very importantly, the social determinants of health are prominently responsible for the health disparities and inequities that we see both within and among populations. So I just mentioned that we're thinking more about health inequities and mental health inequities than health disparities, but we're also noticing that it's the social determinants of health that are driving those differences that we see. And again, the social determinants are shaped by the distribution of money, power, and resources at local and national levels.
Dr. Shim,
yes.
This is Dr. Jeffrey Lieberman. Can I ask just a quick question?
Sure.
So, people with severe mental illness as a group have suffered from a kind of discriminatory access to healthcare and mental health care services, I interpret what you're saying is like within that population of people with SMI, there's also stratification by certain other ethnic or racial or demographic characteristics that make people more or less disadvantaged. Yes. Like in COVID, for example, when the pandemic hit, if you look at the infection rates, within the map of New York City, you would see areas that had higher concentrations, and just so happened our catchment area was one of the worst. And it was, so everybody had COVID, but Washington Heights and Inwood and Harlem were particularly bad affected because of a lot of things which are more sociological as opposed to biological or any other sort of risk factors. But I just want to make sure that I'm understanding in the way that you're presenting it. Would you
That's
agree?
exactly right. And I would say that actually not at all biological. Okay, so those differences in COVID outcomes that you're seeing in certain neighborhoods and certain areas have very little to do with biology, and very little to do also with culture, with certain decisions that those particular populations are making about their health. I'm actually going to go into a little bit more detail about that in a little bit later on, but you're absolutely right. That is exactly what I'm saying. I'm saying it's less culture and it's even less biology, and is much more the extensive, unjust social and economic policies and practices that have been put into effect in those particular communities that lead to those differences. And we'll actually break down what some of those unjust policies and practices are. Great question. Thank you. So this work has been a little bit of an evolution. And so one of your Columbia faculty, Dr. Michael Compton, and I worked on the social determinants of mental health in this compilation book, in which we sought to take all of the best evidence that existed around the social determinants of mental health and how those social factors led to poor mental health outcomes. And in doing that work, that evolution then moved along to me working with Dr. Vinson on social injustice and mental health, because what you see is the more that you uncover and unpack the causes of social determinants of mental health, the more you get to the fundamental underlying cause that drives all of that, which is in fact social injustice. And I'm actually gonna walk us through that whole concept right now. So this is a conceptualization by Dr. Compton and myself. And it looks very busy, but it's actually not that complicated. So I'm gonna walk through it really quickly. We start at the top, and at the top you see adverse mental health outcomes and mental health inequities. And right under those poor outcomes, you see a number of risk factors. That includes things like reduced options and poor choices, behavioral risk factors, psychological stress, and physiological stress responses. We in psychiatry spend a lot of time thinking about risk factors, right? When we think about suicide, when we think about a number of illnesses, our job is to identify the risk factor and then intervene. And many times when we think about identifying that risk factor, we're thinking, we know that a risk factor is something that precedes an illness and increases the likelihood that you develop that illness. So it makes sense that we would want to intervene at the level of the risk factor. But what we've begun to understand is that there are these things called these social determinants of mental health that really set the context and create the environment or create the context by which the risk factor develops. And so if you're trying to intervene at the level of the risk factor, most of the time that the pathology or the thing that has led to the problem set in long before the development of the risk factor. It set in at the time of the development of that social determinant of mental health. So if you're intervening at the level of the risk factor, you're often intervening too late, because the motion has already been set in to create those poor outcomes and those mental health inequities. So then you see here a number of social determinants of mental health, and this is not even an exhaustive list, but this is many of the social determinants that we can think of. And it includes things like adverse early life experiences and discrimination and exposure to violence and conflict, and low education and unemployment and poverty, and things like homelessness and food insecurity and poor access to healthcare, as well as larger environmental things like adverse features of the built environment and pollution exposure and climate change. So all of those things are the social determinants of mental health. Sir Michael Marmot and Jeffrey Rose call these things the causes of the causes, and Bruce Link and Joe Phelan say that these are the fundamental causes of disease. And so as Dr. Vinson and I have done this work, we have come to understand that there are a number of factors that set the context for the development of the social determinant of mental health. And so what we have started to realize is that if you're intervening at the level of the social determinant of health, which is where people say we need to go, we need to move further upstream. If you're intervening at that level, you are still intervening too late. Because again, there has been context that has been set, and those determinants have been set in motion long before we got to the development of that social determinant of mental health. And so what is really driving that social determinant of mental health is the unfair and unjust distribution of opportunity in our society, which is social injustice. And the thing underlying all of that are our social norms. So our beliefs that we have about different people and different populations, who is worthy of advantage in our society, who is not worthy of advantage, and then the laws or the policies that we pass to reflect that belief. So if we have certain beliefs about people with serious mental illness, for instance, if we think that people with serious mental illness have that illness because maybe they are morally failing in some way, maybe they're weaker than the rest of us in society, it stands to reason that we then pass laws that reflect that belief system, including things like non-parity in the medical field. So not giving equal access to the same healthcare benefits for people with serious mental illness versus people with a physical health problem, because those are the beliefs that we have about this population. So our social norms drive the laws, and then the laws determine the unfair and unjust distribution of opportunity and who gets advantages in our society and who gets disadvantages.
Dr. Shim?
Yeah, go ahead.
I hope you don't mind me interjecting.
I love being interrupted, so please go ahead.
So, so if somebody has the attitude that, their affliction with a mental illness has to do with, some type of moral failing or weakness, that's really ignorance. If somebody is at risk or has mental illnesses because of social adversity of poverty or discrimination or other types of social injustices, those are causal factors. So I just want to draw that distinction because both are problems for getting equity and optimal treatment for mental illness, but one is just sheer ignorance, and I know that for a fact from testifying on Capitol Hill many times and seeing it in our representatives. But it's easier to cure ignorance if you educate people. The issues of distribution of wealth and all those things, those are clearly social determinants of health, but those are sort of more sort of harder things to change, unless you have policy leverage.
But Dr. Lieberman, I would submit to you that ignorant belief is actually the thing that drives that social, those economic differences. Yes, absolutely. That you're describing. And that ignorant belief is really powerful because the people who hold those ignorant beliefs are the people that are in power, who create the laws that then lead to the distribution of opportunity that create all of those social causation and those social factors you just described. So that ignorant belief is actually you're touching on the crux of what Dr. Vinson and I are presenting on, because it's those ignorant beliefs that really drive most of what we see in terms of this social injustice. And in fact, that ignorant belief that we have about people with serious mental illness is very pervasive, and it's similar to the ignorant belief we have about Black people and what they are capable of. And it's similar to the ignorant beliefs that we have about LGBTQ populations and the ignorant beliefs we have about Indigenous people. And all of those things are the things that actually drive who creates the laws that then sets into motion those social factors and that causation that we see that leads to those social determinants of health. So that those beliefs are not as educable as we wish they could be. If we could just teach people not to think that certain populations are different and certain populations are less worthy of advantage than other populations, we'd be set. But those beliefs are very intransigent, and it's very difficult for us to make change, because if somebody in power who's passing laws has any of those beliefs, then you see the reflection of these unfair and unjust distribution of the unfair and unjust distribution of opportunity reflected in those laws.
Yeah, I agree with that. I would just make one fine distinction, which is, people who are ignorant or prejudiced and are in power, that governs or that dictates the kinds of things they do, which is, a systemic application of their ignorance and prejudice. On the other hand, they could have legitimate ideological differences. You could be a very kind of conservative, more capitalism oriented, or somebody who's more of a more socialistically minded ideology. So there are distinctions, but this is just a fine point I'm trying to make.
Yeah, and that's a good point. And I would just say that unfortunately, and we're wading into very dangerous territory with you bringing up that fine point, but that unfortunately, some ideologies are less consistent with the idea that all groups are equal. And some ideologies and some political beliefs are actually less consistent with that idea. There are some political ideologies that really put forth that certain populations are more worthy than advantaged than other populations. But again, that gets a little bit thorny. And so I don't want to spend too much time on that, but you do make an important fine distinction there.
Okay, well then the last point I'll make is I agree with you completely, because you know what the biggest oxymoron in the academic world is?
What is that?
Political science.
This is a fascinating discussion. Okay,
Yeah,
I'm going to move on because I want to make sure that Dr. Vinson has enough time, but this is quite a fascinating discussion. So I wanted to give an example of what we were talking about with that social norms and public policies issue. And I think a good example is thinking about crack cocaine. So when you think about crack cocaine use disorder and you think about who are the people that use crack cocaine, I think many of us have certain ideas of who comes to mind. And probably for most of us, we think back to the early 1980s and we think about Black people mostly using crack cocaine. But if we think about Black men, we often think that they are dangerous criminals, violent people who are seeking drugs at all costs and are willing to harm anybody who gets in their way of trying to get this drug. And if we think about Black women who use crack cocaine, we often think of them as horrible mothers, women who put all of the desires for crack use above the needs of their children, and they're not particularly concerned about their families. And so those are the social norms that we have around people who use crack. And because of those beliefs that we intrinsically have, and there's a whole history of the moral panic of the 1980s and why we have these beliefs. But because we have these beliefs about this particular population that uses this particular drug, we went on to pass certain policies to reflect that belief system. And so in 1986 or 1985, we passed the Anti-Drug Abuse Act. This was that jail sentencing disparity, that law that said that there was a 100-to-1 jail sentencing disparity between crack cocaine, which was more likely to be used by African Americans, and powder cocaine, which was more likely to be used by white people. Even though they are the same chemical compound, we still pass this 100-to-1 jail sentencing disparity, saying if you had 1 gram of crack, that was the same sentence that you would get as if you had 100 grams of powder cocaine. So a law that makes absolutely no scientific sense whatsoever was passed based on the idea that this particular population was somehow more dangerous, somehow worthy of more punishment. And in addition to that, this law was passed to really kind of force people who had crack use into prison with this idea that there was harsher sentencing. So there was this push and this focus on jail and prison is where people who use crack cocaine should be. And that if they were going to get any sort of treatment for their substance use disorder, that most of the time that would occur in a jail setting and not particularly in any type of medical setting. And this quote by Drucker kind of gets to that point: the fundamental clinical accountability of drug treatment professionals to individual patients has been subordinated to the goals of the criminal justice system. And so you also see, when you think about this whole social norms, public policies issue, you see this as well when we think about where do we typically treat substance use disorders. So we do not really conceptualize substance use disorders as medical problems. Instead, we see things like AA, we see treatment happening in church settings, which really implies, again, that perhaps we believe that people with substance use disorders have some sort of moral failing or some sort of spiritual failing that they need to work on, which is why we have not necessarily put in the same level of resources into looking at substance use disorders as a medical condition. And let's contrast this belief that we have around this population, people who use crack cocaine, with the ways that we think about people who use opioids. Because if you think about the ways that we have conceptualized the opioid epidemic, we often think of mothers very differently than we think about mothers who use crack cocaine. We also conceptualize the opioid use epidemic as a public health crisis and not a criminal justice problem. And so you see this difference here in the ways that we, in our social norms and our beliefs about this particular population, and it reflects in the laws and the ways we go about managing these populations, where we treat these populations, who is worthy of treatment and who is not. So this belief system has led to the unfair and unjust distribution of opportunity as a result of the laws that we have passed around addressing these issues. And that's why you see these huge inequities as it relates to treatment of substance use disorders, and particularly opioids versus cocaine use. Okay, I have a couple of concepts that I'm going to go through really quickly, and then I'm going to pass it over to Dr. Vinson. So there are a couple of principles that we need to think about when we talk about social injustice and mental health. And the first is this concept of essentialism. This is this belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their characterization. This is a really important concept because it gets back to kind of all of our historical taxonomies in the ways that, like, Linnaeus talked about, you know, Homo affair and all of these groups in which certain racial groups were governed by caprice and certain racial groups were governed by logic and rationality. So this idea of essentialism has kind of moved on, and we now still categorize people and put them into these same categories, not as abruptly as we think about that, but in our work in medicine, we do a lot of categorizing people. And what we do know is that people and populations do not fall into these categories as easily as we would like them, as we believe that they should. Erasure of context is failure to consider the socio-historical context when seeking to understand the etiology of inequities. The best example of this is actually the protest psychosis. So Jonathan Metzl's work on looking at schizophrenia and how, with the rise of the civil rights movement, you saw this recategorization of psychotic disorders in the context, without understanding the context of the civil rights movement, and this idea that Black people who were fighting for their civil rights were maybe more paranoid or more aggressive at that time. Biological determinism is the false belief that racial groups are biologically and genetically different. I think it's really important to point out this concept because it's really heartbreaking to me that many people in medicine still believe in biological determinism, still believe that there are biologic and genetic differences between racial groups, which is pretty surprising because we know that race is a social and political construct. We know that it cannot be biologically accurately categorized. And yet people think that there are different biological and genetic outcomes for people of different races. The best and most kind of shocking example of this is the Hoffman study in 2016, where they asked medical students about different things related to different populations. And those medical students, many of them believed that Black people have thicker skin than white people, or that they have less nerve endings than white people. And then you see this correlation because you see that Black people are less likely to be given pain medication in certain settings. So biological determinism is still very alive and well. Cultural determinism is the false belief that differences in racial groups are the result of cultural factors, which is just as dangerous. This idea that the outcomes that we see are because of cultural belief systems. We see this a lot as it relates to diet. So we often say that certain populations have high rates of blood pressure or have high rates of diabetes because of the food that they eat, because they have cultural preferences that are unhealthier preferences. But when thinking about that, we often fail to think about issues like food insecurity or who has access to healthy foods and who has access, who does not have access to healthy foods. So we don't always look again at structural or policy solutions for why we see these outcomes. And we often tend to think that it must be some sort of cultural factor, and certain populations just like to eat really bad for you food. Okay, a couple of concepts around oppression. This is work by Iris Marion Young on the 5 faces of oppression. These are the many things that we see that lead to these levels of social injustice. So one is exploitation, the unequal exchange of one group's labor and energies for another group's advantage and advancement. We often see exploitation. Of course, the gold standard of this is clearly slavery, but we also see this in modern times with human trafficking, and also even things like treatment of migrant farm workers, treatment of people who work in warehouse settings now in current day. Cultural imperialism is establishing the ruling class culture as the norm and othering all groups that are not part of the dominant culture. So I think the best example of cultural imperialism is when we think about how we calculate odds ratios and rate ratios in science. So you have to create a reference group. And who do we, when we're looking at odds ratios as it relates to race, who is always the reference group? And I just wonder about that, because we don't really question or ask that question, but there's almost a consistency about this idea that the people that are kind of the norm are always kind of set as the reference group. And then it doesn't matter what study or what we're looking at, that then all of those other groups are considered to be kind of what we're looking at differently. And then powerlessness is when oppressed groups lack power or are blocked from routes to gaining power. This is when people are not able to effectively represent themselves or address their needs in their communities. We're seeing this currently as you see voter suppression laws being passed. This is ways to keep people from representing themselves, and that's a form of oppression. Marginalization is expelling specific groups from meaningful participation in society. Clearly, one of the best examples of this is the way the United States has historically treated indigenous populations, but we also see this currently in, we've seen this historically with Japanese internment, and then we also see it currently in mass incarceration. And then of course, violence is exactly as it states. These are threats and experiences of physical and structural violence. Just want to define structural violence very quickly as harm that is done. It does not have to be physical harm, but any kind of harm that people in power put or do to people that have less power. Okay, so the last definition before I hand it off to Dr. Vinson, and I promise Dr. Vinson's about to go, and I apologize for the time that I've spent, but the last definition is I want to define structural racism. So structural racism is a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. This system identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. It's not something that a few people or institutions choose to practice. Instead, it's been a feature of the social, economic, and political systems in which we all exist. And it does not require the actions or intentions of others. This is a very important point, right? Because we're not all racists. Not all of us are actively trying to harm people, but yet structural racism and structural mechanisms are still very much flourishing in our society because it doesn't really require the individual actions or intentions of others. And just to hammer that point home, if we were to get rid of all of the interpersonal discrimination that exists in society today, we would still see racial and ethnic inequities because of the persistence of structural racism, because it doesn't really require that one-on-one or individual interaction to persist because it's baked into our policies. So I want to spend some time talking about some examples. And we've already talked about the war on drugs, so I'm not going to spend any time focused on that. With residential segregation, clearly we understand the concepts of redlining, but I just want to apply this to what we see with COVID. Because there was a study that came out that showed that people who live in communities that are predominantly communities of color have to drive significantly farther to get to their closest vaccination site than people who live in predominantly white communities. And what's interesting about that is that when you hear about the disparities or the inequities in vaccination rates in certain populations, our first thought is, oh, there's vaccine hesitancy. Black populations, Latinx populations are not that excited about seeking vaccination. They're worried because of mistrust of the system and any number of things. But in fact, we don't tend to think about the inequity. We don't tend to think about the unfair and unjust social policies and practices. So that redlining that has created these communities that have been disinvested in makes it harder for people to get to the vaccine in the first place. And so those structural factors are really driving the health inequity that we see. I'm going to spend 2 seconds on mental health, and then we're going to talk about child trauma. So in 2018, about 69% of Black adults with any mental illness and 67% of Latinx adults with any mental illness received no treatment whatsoever. And then we also saw that 42% of Black adults and 44% of Latinx adults with serious mental illness received no treatment whatsoever. When we talk about substance use disorders, these numbers get very shocking. 89% of Latinx adults with substance use disorders reported receiving no treatment. 88% of Black adults with substance use disorders reported receiving no treatment. So I want to pause for 1 second and ask everybody, what do you think is driving this difference? And the question that if we think about this from a disparities lens, we will say, wow, Black and Latinx people, they tend to not really want to seek mental health treatment. Obviously, they have a lot more stigma than perhaps white populations. Or maybe they have less insight into their illness. Maybe they're not really seeing what's going on because they're not as educated about mental health problems or substance use disorders. And we have posited those theories for quite some time. But really, when you ask people why they didn't seek care, cost is the most commonly cited reason for why people actually don't get mental health or substance use disorders. And that's twice as often as minimization of symptoms and nearly 5 times as often as stigma. So we're really seeing that it is a structural driver that is the reason why you see these differences and these inequities and outcomes around mental health access, and not a personal choice or some sort of cultural belief system that's driving this issue. Okay, and so now, Dr. Vinson.
Thank you. And I was actually answering a question in the chat, so I'll send that. But I will be talking about child trauma and how it relates to some of these issues that Dr. Shim has raised. And I am a child psychiatrist by training and in practice. And I'm someone who's always had a private population and a public population. So I see these inequities and this distribution of resources and how different it is on a weekly basis. One of the things that has definitely influenced my framework is when I trained at Cambridge, I had the opportunity to train under Dr. Judith Herman, who wrote the book Trauma and Recovery and really created the concept of complex PTSD. And she doesn't talk about it in a societal sense as much, but I do think that the way that she describes it as something that is inescapable, something that is happening in the context of a relationship where someone has power over you, has a lot of overlap with what we're talking about with social injustice and structural trauma. And she says in her book, the developing child's positive sense of self depends on the caregiver's benign use of power. And I would posit that the caregiver isn't just the parent or the primary caregiver in the household, but when we're talking about children, when we're talking about population mental health, that the caregiver is all of these different systems that are tasked with helping usher people from childhood through adolescence into adulthood. And that these systems, the education system, the juvenile justice system, the child welfare system, the economic system, all have tremendous power. And there's a choice that we make as a society about how that's used, whether it's done so in a way that promotes the mental health of children and their healthy development, or that promotes mental illness. Next slide. So these are three people that I have been in contact with in various capacities as a clinician and then as a forensic mental health consultant. One was an adult defendant who I met in a capital murder case. And in my forensic consultation work, I'm often a trauma expert, and I talk about developmental issues that sort of led the person to being where they are. And he was in his mid-30s when I spoke to him, but he said to me, I was proud to make it to 21, even though I was in prison. And we'll come back to him a bit later. The second was a young man I met in my private practice who said, when I was asking him about his childhood experiences, his reply was, school was all I ever really had to worry about. And the third was a detained teenager that I met when I was providing direct patient care in a juvenile justice facility, who said, they say I'm supposed to care about people when ain't nobody cared for me. Next slide. So there are things that we know promote the mental well-being of children, that we know promote healthy development, that we know set people on a trajectory to be mentally healthy adults. And all of these things are positive childhood experiences. Often we talk about the adverse childhood experiences with the ACEs. But if we're talking about mental health care and not just mental illness, then we need to think about those things that promote a healthy growth and development as well. So some examples: a true home, housing, stability, food security, having basic needs met, a reliable caregiver, a consistent available adult who's able to instill a sense of worth and advocate for a child, given that children often are voiceless and powerless. Educational opportunity in safe schools that prepare them for career college and that have special education resources available to them if needed, and healthcare, whether that's medical or mental, and that there's both adequacy and access. Next slide. So those are things that we know are related to healthy development, both physical and mental. And when you look at that list, all of those things require a certain minimum amount of income in order to obtain those and to have those things consistently as part of a child or an adolescent's life. In this country, 12 million, 1 out of 6 US children lives in poverty. And I actually had to update this slide because of the recent administration's efforts at supporting families better. And they've already paid off in terms of the child poverty statistics. So it's an example of how poverty really does make a difference. When I've done this talk earlier, it was 1 out of 5 US children. And just for those of you who've never actually looked at that threshold, it's $25,710 for a family of 4. So while the numbers have gotten better, you can imagine there are many places in the country where $25,000 is not going to be enough to consistently meet the needs of a family of 4 people. And so that is an underestimate of the people who are having these basic needs continually undermined or are at risk. Of the people who are experiencing, or the children who are experiencing poverty, 73% are children of color, and child poverty rate is nearly 1.5 times higher than that for adults ages 18 to 24. And the reason I point that out is because often when we're talking about the disadvantaged members of society, children aren't thought of as one of those groups. But if you look at the numbers, they absolutely should be. And when we think about the fact that children do not have a voice, they do not have a vote, there are all these things that they're dependent on the adults or the systems around them to take care of. Children are a disadvantaged group, particularly when you look at poverty in the country. Next slide. So we have 1 out of 6 children in poverty, an even higher proportion in lower income families that can't consistently provide those positive childhood experiences to them. And this is allowed to happen in a country that spends $732 billion a year on defense, which is more than the next 10 countries combined, where a majority of US lawmakers are millionaires, and where 76.8% are men. So this is an issue that is one we don't have to have in this country. It is one that we have decided not to allocate appropriate resources toward addressing. Next slide. And so what we see in those children and in those children that aren't captured by that statistic because they're lower income but not quite under that threshold, is that all of these positive childhood experiences are at risk. And we have the possibility for adverse childhood experiences, including those social determinants that Dr. Shim spoke of earlier. And then some of the ones that are more educationally specific, such as under-resourced schools, and the things that the adults who are their caregivers or that who want to be their caregivers are going through themselves. Someone in the chat brought up the issue of school resource officers and mental health care services. And actually, Andrea Whited, hopefully I'm pronouncing that right. But to her point, there are 1.7 million students in schools with police but no counselors. And for those of you who are not familiar, school resource officers are police. They're just police who are called school resource officers. They have no additional resources. There's no requirement that they have training in mental health. There's a requirement that they have training in children. They're literally just police officers they've been in school. 1.7 million students are in schools with police but no counselors. 3 million students are in schools with police but no nurses. 6 million students are in schools with police but no school psychologists. And 10 million students are in schools with police but no social workers. We are choosing to spend hundreds of thousands of dollars on police officers in schools rather than support services and interventions that we know children need. And those numbers sound bad, but they're even worse when you consider the fact that the schools that need these professionals more are the ones that have fewer of them and have those resources allocated to school resource officers instead. So this gets back to that ignorant belief, right? So these kids in these, the question said public schools in poor neighborhoods, there are ignorant beliefs about who those children are, right? There are ignorant beliefs that those children are dangerous, that they need correction, that the juvenile justice system is the appropriate intervention for them. And there's a lack of appreciation for their trauma, for their pain, for their need for help and for services. And there's a term that they use in the criminal justice realm when they're deciding between trying a juvenile as an adult versus a child, that's incorrigible, right? That can this person be redeemed or taught or set on a different path in life? And when you look at those numbers, it tells you the beliefs that our society has about an entire group of children. Next slide. And so going back to Miguel, and I did change his name for the sake of the presentation, who said I was proud to make it to 21, even though I was in prison. He was incarcerated from the age of 17 to 21, and he was in one of the states that locks 17-year-olds up with adults. He was in violation of plan, which is juvenile probation, basically, after being found in possession of a small amount of marijuana. And his original charge was one that was nonviolent. So he was incarcerated during this really critical developmental period of his life for something that it would be really hard to argue posed some great threat to society. Next slide. So how did this happen? And sometimes we will look at the behavior and we'll say, you know, he had a learning disorder that wasn't addressed, and maybe he had some ADHD or trauma or something, but I want us to go upstream, as Dr. Shim mentioned earlier. And sometimes we may do a pretty good job at the family dysfunction part, so the very bottom of the inverted pyramid. And in his case, certainly had a lot of those adverse childhood experiences related to his mother and her substance use, his father and his incarceration, and some of the abuse that he experienced that from other people in his family. We're less likely to think about neighborhood issues like neighborhood violence, housing and food instability and victimization that happen socially there. But what is it that created the setting for this child to experience this throughout his childhood and adolescence? And there was multi-system failure that was at play. He was someone who had 12 different foster care placements. unmet educational needs, and unmet mental health needs. And again, this isn't because he as some child was willfully deciding not to engage or not to learn or making some conscious decision, but there were things that were not put in place that should have been to help him through this time. So this was a state that has low mental health spending per capita, one of the lowest rates in the country. Child Protective Services was chronically understaffed. And it was during a time when there was a very punitive stance toward adolescents. So this was when there was that narrative around super predators, and this was a young man of color. Next slide. And so what we see is that these unmet needs, because of the choices we're making about not allocating resources to children, equate to juvenile justice involvement risk factors. And we know that juvenile justice risk equates to adult criminal justice system risk. And so all of these things, this list of unmet needs that he had are things that we would also see on a list of things that we see in higher rates of people who have juvenile justice involvement. And one of the things that we don't pay attention to as much is the foreshortened sense of future. And I thought that his quotation really captured that he was someone who seriously did not believe he would make it to be 21. And so all of these things that we expect children to do, like be invested in school and plan for their future and want to get an education so they can have a good job when they grow up, it presupposes that a child has had a sense of safety and security that allows them to see adulthood as something that is a likely outcome for them. But we have created a society where many of our children don't have that as their reality. Next slide. And this also sets the stage for the overrepresentation for youth with mental illness in the juvenile justice system. So 70% have a mental illness and 30% have a serious mental illness. Next slide. And part of how we miss this and get this wrong is our own diagnostic criteria and our own way of thinking about trauma. And this actually, I think, also relates to that issue of pain and whose pain we pay attention to. And I think that applies both to physical pain and to mental pain as well. Traumas that impact groups that are marginalized, that are not part of middle-class white America's experience, are ones that we often aren't prompted to ask about, are ones that are not reflected in our diagnostic criteria, and often are not in our widely used instruments. That's not to say that they're not harmful to people or that they don't impact people's mental health, but we don't pay attention to them. And so there's a way that because of how we operate as mental health care providers, in part because of the structure that we have by things like diagnostic criteria, that we are bystanders to the trauma and to the pain of children like Miguel. Next slide. And even worse, there are ways that because that trauma is undercounted and those externalizing behaviors are the focus, that we can label children with diagnoses that are harmful as well. So there's a way that we can, as a system, actually cause harm to the people that we purport to be serving and helping. As someone who does criminal justice consultation work, I have seen it again and again, where you have children and adolescents like Miguel who have been seen by numerous mental health care professionals, maybe not consistently or over a long period of time, but who get diagnoses such as oppositional defiant disorder or conduct disorder or antisocial personality traits. And there is no or little to no acknowledgement of the traumas that these children have experienced, the ways that that may be manifesting in their behaviors, and of the ways that their experiences of life may make it hard for them to engage or trust people in positions of authority. So it's an intersect between this inequities in our mental health care system that actually feeds into the criminal justice system, because those same diagnoses are used to justify things like harsher sentences and like trying adolescents as adults. What you write in your notes, what you capture and what you don't, has implications for people who are at increased risk for involvement in the criminal justice system. And I put criminal justice in parentheses. Or in the next slide. And the other thing about the trauma that we don't capture is that it's not post. These are things that are ongoing, that are inescapable, and have nothing to do with the choices that these children are making. Next slide. And so in this video, it's a young 10-year-old kid playing basketball in his front yard. And you see that he sees something on the side, hides behind his car. And it was a police officer driving by, and his dad saw the video on his home security surveillance camera and asked him why he did that. And the young boy replied, because they killed George Floyd. And I play this because it's just an example of how inescapable racial trauma is, and how it's something we often don't ask about and would not capture. So when we think about this criminal justice race issue, this is something that it's not really debatable. Most judges acknowledge the system is racist. 80% of state judges are white. And it is a system that consistently has different outcomes based on socioeconomic status, based on race, and not only based on race, but also on how dark-skinned a Black person is. Next slide. And when we go back to school and we think about the school to prison pipeline or the connection there, of course, this was the previous Secretary of Education who had a great deal of influence over how schools were structured in Michigan, and after that experience was put in a national position. And what we saw happen in Detroit, the major city there, is that the Black male high school graduation rate, after many of the reforms that she put forward or that she supported, the Black male graduation rate was only 23%. So only 23% of Black males were graduating. In this country, if you're a Black male and you don't have a high school graduation, your chance of incarceration is 60%. So when one system gets it wrong, especially when it comes to children, it sets the stage for the inequities that we see in adulthood. Next slide. So next we will go to a call to action. So Raymond Santana was one of the formerly known as Central Park Five, now known as the Exonerated Five, who I'm sure with you all being in New York, you're very familiar with this case, but sentenced at 14 years old after a false confession, was incarcerated for 7 years. And then it took an additional 12 years for the civil suit in his case to settle. I had the opportunity to interview him a couple of years ago. And one of the questions from the audience is, what do we do about these issues? How do we help address them? And one of the things that he said is that we need all hands on deck. So he emphasized that we don't all need to be lawyers or judges or politicians, but that there is room to do this issue wherever you are. Next slide. And that goes along with an Arthur Ashe quote that says, start where you are, use what you have, and do what you can. And I know that sometimes as mental health professionals who work with mental health professionals who are surrounded by mental health professionals, sometimes we can take our privilege for granted, but you have a tremendous amount of privilege as an educated person, as a professional, as someone who gives diagnoses, as someone who is part of a prestigious medical institution, that there are things that you can do where you are that don't require you to take another course or another position, but I assure you there is injustice where you are that you can be a part of addressing. Next slide. So 3 steps to advocacy. Develop a knowledge base, because the reality is this isn't something that we have been taught about consistently or well throughout our medical training. Recognize injustice in your role in addressing it, and respond to injustice through an iterative, sustainable process. And that sustainable part is really important because this work is hard, and these issues are entrenched, and it's going to take time. Next slide. And your advocacy ain't like mine, so a nod to B.B. Moore Campbell. But this slide just is a few examples of the way that advocacy can look. If you are in a position as an educator, then weaving these issues of structural competency and social injustice into the rotation sites you choose, your curricula, the faculty that you engage, can be an example. Dr. Nelprin, who was at the APA for many years, really mentored and sponsored an entire generation of minority psychiatrists. Trauma and Recovery was Judy Herman's book.
Sarah, I think we lost your audio.
Yeah, Sarah, we can't hear you.
It's very, it's low. I see you might be saying something, but it dropped out.
Hello?
Yeah.
Oh, there you are.
You're back.
Sorry. Yeah, I don't know what it did. But Trauma and Recovery is just a great example of how writing can be part of advocacy. And I'd say Dr. Shim has taught me a lot about that. And then in the top right corner is Dr. Joe Bona, who was an advocate here in the Atlanta, Georgia area, who did a tremendous amount of work on the state level with policy and legislation here. And also was a tremendous mentor to me. And one of the reasons I put him on this slide is because he's a great example of how intentional mentorship and sponsorship of people who don't look like you can be incredibly powerful. He is someone who was a white man who was the son of a physician, who was an incredible mentor and sponsor to me, a Black woman who was a first generation physician in her family. Next slide.
Okay, so I'm gonna take 2 minutes to wrap up this and open up the floor. I see we have a lot of comments in the Q&A, so I want to get to them. So, you know, as Dr. Vinson described, we're currently in the state of inequality, and many people think that the goal that we're trying to accomplish is to reach some sort of state of equality, where we focus on fairness and making sure everybody gets to the same evenly distributed tools and assistance to solve the problem. But as you can see, that if we focus on fairness, we're going to be coming up too short. So one of the goals is really to think about equity, to think about custom tools that identify and address the inequality, and then also to think about justice, to think about fixing the system to make sure that everybody has the same access to tools and opportunities. So that's the goal, and some other ways, including thinking about advocacy, is work that we all can do personally, involves education and self-reflection. So the concepts we're talking about here today are not things that you learned in medical school or in your professional education. They're not things most people learn in college unless they took some sort of ethnic studies or anthropology. And so there's work that people need to do personally to come up to speed on this. And so here are a couple of recommendations. I would just say that we're all very busy professionals, and so sometimes we don't have time to read dense books. And so this is the page of things for people who don't have time. These are books that are easier to read. They're more fun, I would say. They're less dense, but also a number of podcasts and a number of documentaries that really moves us in the right direction. So really the excuse that you don't have time is not really a good one, because there's lots and lots of ways to educate yourself on this work. With education, we also have to self-reflect. And so that involves practicing cultural humility, which is committing to this lifelong evaluation of self-evaluation and self-critique. It doesn't mean that we're going to take a class or do a grand rounds lecture and all of a sudden be competent in this area. But we have to realize that this is a lifelong process, and we have to have this desire to fix these power imbalances between providers and clients, and to develop community partnerships in the organizations which we serve. And then of course, we need to practice structural competence, which was a concept created by Jonathan Metzl and Helena Hansen, which is the trained ability to discern how a host of issues defined as symptoms or clinical problems or attitudes or diseases are influenced by those upstream social determinants of health. But ultimately, at the core of all of this, I mentioned before, we are trying to change social norms, and we're trying to address public policies. And so to do that, we need to enforce social norms of inclusion and equity. We need to make sure that in our work settings, in our home life, wherever we go, if people aren't practicing social norms of equity and inclusion, we take the responsibility to educate people. And if most of the time that ignorance can be educable. So we talked about that at the top of the presentation. A lot of times you can educate people who are ignorant, but for those people that no amount of learning is going to change how they feel about things, we have laws. And I would say to use the laws that we have to keep people who have these types of negative beliefs about certain populations away from positions of power, away from harming, for instance, medical students or residents or in any type of situation like that. This work around social norms also involves observing and challenging your own implicit biases and also evaluating and breaking down any unnecessary hierarchies. Some hierarchies are really important. If you're working in a surgical suite, I think sometimes you really need a clear hierarchical system. But many of the things that we do in medicine and in psychiatry are not actually necessary. The hierarchies are not necessary, and they're really in place to help the people in power feel good about their power and to help the people that are not in power, most often our clients, feel less than. To advocate for public policies, we need to move beyond the walls of our clinics and hospitals and treatment centers and advocate for those policies that address social determinants of health. We need to get political. We need to communicate with our elected officials. We need to promote equitable representation, and we need to form partnerships in our communities with coalitions. So I'll wrap up by saying that political stances and policy interventions are required. In psychiatry, we have this idea of the tabula rasa. We think that we need to be neutral in order to be effective. But if you remain apolitical or neutral, you are in fact taking a very clear political stance because you're tacitly accepting the status quo. So to wrap up, progress is when we make change through the passage of legislation, court rulings, and other formal mechanisms that aim to promote racial equality. And I think that we have seen, both in psychiatry, but also throughout our society, lots of examples of progress. We've really come very far. But I think that we always have to remember that with progress comes inevitable retrenchment. And retrenchment refers to the many ways in which that progress is often challenged, neutralized, or undermined in key policy arenas. If you're not prepared for the retrenchment, it can get very overwhelming. It can get very defeating and depressing, and you can feel very pessimistic about where things are going. So I think it's important that as we move forward and try to make this change, that we're ready for the inevitable retrenchment. So we'll end with this quote from Congressman John Lewis, because I think it gives us that hope for the struggle and the work that we have ahead of us. And he said, "Do not get lost in a sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble." And I think with that, we'll open the floor.
Thank you so much, Dr. Ruth Shim and Dr. Sarah Vinson. That was an incredible grand rounds. And I'm gonna second Dr. Sydney Hankerson in the chat, who said it was a masterful grand rounds presentation and presenting complex issues in a clear and compelling way. And in addition, you gave us real concrete ways and specific recommendations about how we can each get involved in this work going forward. So really thank you for that. There are a number of questions in the chat, so I really do want to get to some of those. So let me go forward, and there was some questions about the NIH requirement to count by race and ethnicity in samples and research studies, and how to do that, how to make the race and ethnicity reporting more meaningful, so that we can better disentangle all of the things that race may be a proxy for.
Yeah, that's a great question. And, I think there are scholars that are thinking about this all the time, because race is a proxy for so many things, right? So we know race is a proxy for socioeconomic status, it's a proxy for culture, it's a proxy for genetics, it's a proxy for many things. And yet it also exists as a construct that has a lot of meaning, because, because of racism and the things that exist, it has created these these very significant differences. So the answer is definitely not to look at race. I think that somehow we have to get more precise in looking at why we are looking at race, and we have to be more precise about looking at race as a proxy. So we have to make sure that we're not saying that race is kind of the causation rather than race being the proxy. So I advocate for us doing better work around being better about our racial categories. I think that we have to do a lot more around how we ask people how they self-identify as it relates to race, because we also do a very good job, a very poor job in research of just looking at people and assigning racial identities to people without really knowing what their social identity is. And then we have another problem where many subgroups, for instance, Asian populations, we're not getting to the variation within subgroups, and so we're not looking at the issue with enough granularity. So there is a lot of work that needs to be done in this space. I don't have answers. I just think that we need to be a lot more precise.
Another question that is in the chat by one of our chief residents is saying, without endorsing any particular ideology, it does seem like the class stratification and division of labor inherent in modern capitalistic economies actually requires inequality that can become racialized. Could you comment on that?
Dr. Vinson, do you want to comment on that?
Sure. So one of the things that I would say is that it didn't become racialized. It was designed. Like, race in this country was created to make it easy to designate certain people as property and other people as, people. So it wasn't a byproduct. It was very intentional in how this was, how the hierarchy was made in American society, and that it was racialized. I know Dr. Shim talked about maybe not having time to read a whole lot, but Caste does a beautiful job of exploring this and talking about it, right? And so I would recommend that book. I think there is a way that capitalism is a system that can set up sort of people who win and people who don't. But there are other capitalistic countries that don't have the same degree of inequity that we have in America, and that don't have it to the same degree by race. And so there's an issue with capitalism, but there's also an issue with the way that we were constructed as a society from the very beginning when it comes to race, and that even if we got rid of capitalism, that whatever system we replace it with would still, I am sure, be racialized in terms of who wins and who loses, because as some have said, that's the great American sin. And there's a way that I think sometimes we're more comfortable talking about sort of economic structures than the racism in this country, and the fact that it has served a purpose for a powerful group of people throughout this country's creation and duration.
You might call it economic gerrymandering.
Yes. I would also add that another good discussion of economics, capitalism, and slavery, and the direct connection between these things is in the 1619 podcast. So there's one episode that's devoted to this.
There's another question about how would you suggest working with people in power to do the personal work when their actions demonstrate lack of motivation to do the work, particularly when there's virtue signaling without action taken?
That is a great question, and it's very challenging. We have to move people along, and it's funny because my recommendation on this issue is to read Beverly Daniel Tatum. So why are all the Black kids sitting together in the cafeteria? So she talks about racial identity development, and she talks about how there is Black racial identity development and there is there is people of color racial identity development, and then there is white racial identity development. And that I have found that some of the most effective people doing this work are white men who are far along in their racial identity development. They've kind of gotten to the end of that stage. And I also just point out, it's very interesting that we have racial identity development as a very clear developmental process that I'm gonna venture to say that most of us were not taught about, right? So there is this entire well-studied, well-backed up science around racial identity development, and we spend a lot of time on development in our learning. And there is never any talk about racial identity development. But so I have found that white men who have proceeded through the stages of racial identity development and have gotten kind of to kind of the end stages can be the most effective at advancing these policies and moving us in the direction we need to go in, because they understand and they're willing to kind of give their power in the name of achieving equity and justice. But for those that are in power that have not gotten to that point, one of the things that Beverly Daniel Tatum talks about is how important it is for other white people to help bring those people along in their racial identity development. So this is work of white people to be able to help other white people who are in power move into this place and prioritize this work. And so that's as much as I can give, and then I would just say that it's on white people to kind of move us forward in this space.
I love the term virtue signaling. I never heard that before. It's like walking the walk, talking the talk, but not walking the walk. Jean Marie, can I just make one comment because I have to go to another meeting? Is that okay?
No problem. Go ahead.
So. Anyway, this was a really wonderful set of presentations, and you did make me uncomfortable, but for a good purpose, I know. I two comments. A lot of it has to do with individual people needing to come to terms with things, and I love the dictums you had, including the Arthur Ashe one being a tennis player. But much of it is really social engineering, which needs to be affected through legislation and policy. The other area that I think bears responsibility and is a point of leverage is the fourth estate, the media, because the only way you influence policy and legislation is through government leaders and through public opinion. And the thing that influences public opinion most of all is the media, which are not held accountable to really any standards other than economic, commercial, audience viewership. So I just make that comment.
Yeah, thanks for sharing that point. And I think the work has to do that social norm piece is a lot about mindsets, and the media it does a lot to help us think about and shape our mindsets. And it's not just the media, right? Because there's also social media. There's any number of influencers, but I agree, it's a really significant piece of this.
I will comment just that my along the lines of racial identity formation and learning about that, my favorite class in college, I was a psychology major, was the developing concept of race and ethnicity in children. And it almost led me to become a psychologist instead of a psychiatrist, but that's an aside.
But I just want to point out, that's something that we can do as medical educators, right? I went through 7 years of training after medical school, and that was never part of any class I took, right? And I went to places that are thought to be fairly liberal and progressive. So if you're an educator, don't allow that to be a gap in your curriculum. That is something that you can choose to do today.
Exactly. And there's another question in the chat about a tension between biological determinism of serious mental illness, such as schizophrenia, and social determinants of health, and how to more explicitly move toward a formal plan of including racial equity and inclusion, social determinants of health, and structural competency in all biomarker research and other biological initiatives. I don't know if you have any comments on that.
That I agree. I don't have a lot of comments. I think that, I think one of the challenges is that the NIH has not traditionally prioritized, especially from a mental health and substance use perspective, has not prioritized the consideration of social determinants and social and economic factors. And so, what we have is the decade of the brain kind of led to this rise in really thinking about and trying to find genetic and biological markers of mental illness and disease. And we've gotten very good at that. We're doing great work in that space, and yet still we see massive inequities still, right? So the work that we're doing around biology, around genetics, in medicine is leading to a whole lot of really great discovery and research, but yet the gaps continue. So we're obviously not getting it done. And I think that we really need to be thinking about that issue, about what are the things that we need to be thinking from a research perspective about how to close these inequity gaps. I do want to comment because there was a specific comment in the chat that I did want to address around disparities and the fact that Black people use substances less, and that have lower rates of depression. And those findings are I agree on those findings, but also point out that those findings are often very inconsistent, partly because we have such a poor way of measuring and looking at race, that one study will show one thing and another study will show another thing. But one thing we do know because of the Surgeon General's report in 2001 on mental health is that the inequities that we see around mental health they're not prevalence rates or incidence rates. They are access to care rates. They are quality of care. Those are the inequities. So even if the rates of depression are lower, the chronicity of depression is worse in Black people. The outcomes are worse. So it is not that the prevalence of the condition is different, it's just that the outcomes of the condition are worse, and the debilitation of the condition or the ability to get treatment and good treatment for the condition, those are the differences that we see.
Another question in the chat is oftentimes because of the way medical curricula change over time, trainees tend to be better versed and more invested in discussing the impacts of racialization and inequality or inequity in the medical setting. What are ways that you found about effective in loosening this hierarchy so that teaching upwards can happen to diffuse this knowledge and framing it in more effectively?
That's a great question. I know Dr. Vinson and I share that very strongly, that belief. I would say that that's a hierarchy that doesn't need to exist, right? So, we do in fact set up this system or this idea that perhaps residents don't have the same level of expertise because they have not proven themselves and therefore they can't be experts on anything. But most of these people have taken those classes that you took, Dr. Alvis Bradford, when you were in college. And so they actually have significantly greater knowledge on these topics. And so their expertise should be considered at the same rate as the so-called experts in psychiatry. And we need to start breaking down those unnecessary hierarchies so that they can do that teaching. So I would just say, the people who are in charge, the course directors, you have the ability, just as Dr. Vinson said, you have the ability to make those changes. Some of the best programs, like the model programs in psychiatry residency program, have been very much, in terms of didactics, have been resident run, resident driven, resident taught.
And there was another question also about, sort of what a department could do to focus more intentionally on racial equality and equity and inclusion, and how can we further involve people of color with lived experience as leaders in this process, which is sort of similar, I think, a little bit similar.
Yeah, and I put a couple of articles and resources in the chat. The other thing that I would say is ask your people and don't get defensive and listen to them. What people often will describe to me, and even sometimes with the residents, is like people ask our opinion, but they don't really want to hear it. So ask and listen to the people who are there. Sounds simple, but it's often not done.
Thank you so much. I just want to thank you both. There's a lot of comments in the chat about how fantastic a presentation this was. I wholeheartedly agree. I'm delighted to have you both here and to have this content for our department. And there was, Dr. Lee commented on the attendance, very highly attended grand rounds. I think that people are really, and very interactive, people with lots of questions in the chat. So I really think people were hungry and really invested in engaging in this material. And if you could just put up the resources, if you're able to share the screen. There was a comment also, people want to take a screenshot of the last 2 slides of resources where like how to engage in this work, where it had the podcast and the books. I don't know if you're still able.
Oh, okay, hold on.
Okay.
The, so one of these slides, right?
Yeah, yep.
Is it this one? And
yeah,
the one before this?
Correct.
Okay, so I'll just give a little bit of time on this one and then I'll move to the next one.
And just thank you. Just, yeah.